Hi everyone, and thanks to Paul for inviting me to speak today. My name is Christina Prickett. I'm a clinical psychologist at Peter Mac in Melbourne. I've worked at Peter Mac for a bit over 3 years now, working within the clinical psychology team, and that service is a service that's available to all Peter Mac patients, and will work with patients with varying clinical presentations, with the general limit essentially being that they have cancer-related concerns, and we'll see people across their disease trajectory and across disease types as well. And in the last couple of years, I've had the opportunity to develop some links with the acute and persistent pain service, and really today we're going to talk a little bit about that service development. I'd like to talk today, I guess, as an overview of why psychosocial care is important in the management of cancer pain. Talk specifically, and I probably won't go into it in too much detail given what Tim's covered today, but a little bit about our clinic itself and our clinic development experience. Speak a little bit specifically about the role of psychological management and the research around that specific to cancer pain management, and then touch on, I think, where there might be really valuable ways to progress our service, but also, I think, develop appropriate cancer-specific interventions for pain, and that sort of feeds into where the research might develop in this field as well. So generally speaking, the evidence suggests that psychological distress in a cancer population is relatively high, with up to 60% of patients experiencing some clinically significant distress at some stage in their cancer journey. But what we know from our numbers and sort of the general numbers of referrals in cancer settings is that very few patients actually get access to or referred for psychological intervention, and that number being somewhere between 2 to 5%. So there's an unmet need in the population. We also know, I guess, has been touched on quite a lot today, is that moderate to severe pain is reported across the cancer stages, with 55% of people reporting moderate to severe pain in the treatment phase, 66 in the advanced or metastatic stage, and 38 who have completed curative treatment are in that survivorship phase. Bringing these together, I guess there's an understanding that through research that cancer patients experiencing pain report higher levels of distress than those who are pain-free. We also understand through the chronic pain literature as well that psychological distress is a risk factor for developing persistent pain, and in the other direction as well. So there's likely a bi-directional relationship between pain and psychological distress, which really sort of highlights the importance of a psychosocial management approach within cancer pain management. Getting more specific, and I guess Mike touched on some of these elements earlier today, is that psychological factors influence the patient's experience to pain and their response to pain treatment, and that maladaptive responses to pain, including catastrophising, avoidance of behaviours, can really predict and are associated with poorer pain treatment outcomes. And so I think as well it's really important to try and address these issues as early as they arise in our patient group to limit the impact that pain might have in the long term, particularly given the level of pain that is evident in the cancer population. Wanted to bring it back, and I'll touch on a few slides today that is just from a study that was conducted a few years ago now, but it's really a descriptive review of psychological cancer pain and factors associated with psychological cancer pain at the different treatment stages, along with the psychological interventions and the evidence for interventions at different treatment stages from a psychological and behavioural perspective. While there are some limitations to the study, it does sort of give an indication of sort of where the research is at in comparison to perhaps the more generalised chronic pain literature. So at the diagnosis and treatment phase, there are a range of factors that have strong evidence for being associated with pain, particularly depression, distress and anxiety, which we've spoken about. Uncertainty, PTSD, less strong evidence, but as with most of the research, that's not necessarily indicating that there isn't a relationship. There's just less less studies that have been conducted, and the quality of those studies isn't as robust as some of the other evidence. In terms of survivors, I think this is a really untapped area in a lot of respects. There is research, but as you can see, a lot of it is cross-sectional, and so we really don't have a really solid understanding in survivorship about the psychological factors related to cancer pain, although I think we can assume that with further research that a lot of these factors will be similarly strongly associated. And in the advanced disease stage, again, less evidence, but strong associations with psychological distress, pain, coping and appraisal, moderate associations with desire for hastened death, and a lot of what the studies that have been conducted suggest that the association is not so much necessarily a direct link, but more associated with the sort of functional implications that the pain impacts. And interestingly, although there's not a lot of research, there's actually some evidence to suggest that patients' reported pain levels are associated or predicted by their perceived amount of support from caregivers. So people who perceive that their spouses or significant others are less understanding report higher pain levels, which is interesting when you're thinking about a biopsychosocial approach. So Tim has obviously given an overview of our clinic at Peter Mac, and to start off with, it's a 1 half-day clinic per week and made up from the medical side of things of a pain consultant, pain fellow and specialist nurse. And in the past 2 years, psychology and psychiatry services with my colleague, consultant psychiatrist Dr. Sophie Burke, have been incorporated into the clinic. This sort of came out of recognition from Tim and his colleagues of patients presenting with high levels of psychological distress and positing that perhaps there was an unmet need in terms of multidisciplinary intervention, and that perhaps if there was more access or better relationships with psychosocial services, that patients may have beneficial outcomes in terms of their distress, but also for managing their pain. I would like to say that Tim stole my slides, but it's the other way around, so I won't go into this in too much detail, but as Tim said, that they administered the DAS to a range of patients a couple of years ago across a 12-month period, and what they found was that 66% had at least mild symptoms of at least depression, anxiety or stress. And this is what Tim showed before, which again, more than 50% of patients in each of the domains of depression, anxiety and stress also demonstrated symptoms in at least the mild range, which I guess is consistent with the broader literature and what they expected. But I think this has well motivated some of the discussions around developing more closer links with our psychosocial services. So that's essentially what happened a couple of years ago. I work within the psychosocial oncology program at Peter Mac, and that's made up of clinical psychologists. There's a team of us. We also have a few interns every year, a team of psychiatrists. There's a couple of consultants who are part-time and registrars, and we also have a team of social workers. And the team works with both inpatients and outpatients across Peter Mac. So Sophie and myself in this time have attended clinics, so we preferentially, I guess, take on referrals to develop, I guess, a more specialised understanding of patients seen within the clinic. We don't see them exclusively. Our colleagues will see some of the pain patients as well, but as much as we can, we've tried to develop our expertise in this area. We're having fortnightly multidisciplinary meetings, which has been really fantastic for treatment planning, understanding and education between the specialties. And as I said, we work with both inpatients and outpatients. Currently our model, and I'll talk a little bit more about future directions a little bit later, currently it's a referral-based service offering individual assessment and therapy. So we see patients one-on-one, and patients are identified essentially through clinicians who are seen within the clinic or the nurses and referred directly to Sophie and or myself, who will provide an initial assessment and then refer to each other or to social work or other services as we deem appropriate. In terms of what we do once we see them, I guess from my work, managing the pain specifically, and today I think I'll talk specifically about the pain management approaches. We use a range of therapeutic modalities in our work with patients to address other concerns, but in terms of managing pain in this setting, it's informed by chronic pain research and, as Mike sort of touched on earlier, the cognitive behavioural therapy self-management approaches have the largest quality evidence base. And there is also growing evidence for acceptance and commitment-based therapies. And at the moment, they're sort of showing comparative findings to CBT, but there's very little ACT research in cancer-based pain at the moment. So in terms of the cancer pain intervention literature, I'll talk a little bit about that. CBT similarly is the most research intervention approach. Shows medium effect sizes when you're talking about pain intensity and interference scores. And there's a strong evidence, for CBT, including education and relaxation during treatment phases. But actually when you look at the evidence for cancer survivorship and advanced disease, there's actually less that's been looked at in those areas, which is quite interesting, and that probably as well indicates sort of follow-up and access to services. So this is a bit of a summary from the study I was talking about earlier around which type of behavioural and psychological interventions have evidence for managing cancer-related pain during diagnosis and treatment. And as you can see, there's quite strong evidence for hypnosis, relaxation, CBT and education. I think we'll hear a bit more about education later, which will be fantastic. Interestingly, there's not a lot of evidence that supports meditation effects on cancer pain at the moment. I guess this is something that I'm quite interested to understand a little bit more about. I think meditation can be used as a broad framework. I think we need to be careful about using somatically focused meditations with patients with pain where there's such a somatic focus already on the sort of physical experience, and that's quite similar to, I think, the thinking that's happening as well in the fear of recurrence literature, that somatically focused meditations as well can't be helpful, but that's just an interesting point. I think I'd like to learn more about that in the future. In terms of in survivors, there's a lot less evidence actually, so there is physical activity is obviously well supported. The suggestion here that the evidence is weak across the other treatment modalities is, again, somewhat reflective of the level of research that's been conducted. And in advanced disease, there is some strong evidence for pain coping skills and hypnosis, but it's not clear which components. So because there's not that much research, they've lumped everything in together. So it's difficult to see which components of these strategies are effective. What we're doing is really drawing off this evidence base and using a CBT framework within our pain-specific work with patients. And Mike really touched on a lot of the specifics of this earlier, so I won't go into that today. But I did think it would be important to touch on some specific considerations that we've started to realise in this population. And I think that's understanding the context of the cancer to the patient is probably the starting point. And particularly what we've noticed is the impact and the grief and loss associated with functional changes associated with patients' pain. So often the treatment that they've had or the surgery that they've had really does significantly impact their function and their day-to-day life. And there's a lot of loss, often a lot of anger, a lot of sadness about the fact that they're not able to do what they used to do in the way they wanted to do that. And often that grief can be a barrier to engaging in looking at doing things differently in their life. So often, even before we get into some of these specific management strategies of managing the pain, we need to sit with the patient and talk about this change to their life and the meaning that it's had. And I think that comes as part of as well getting that collaboration and buy-in to why might it be important for me to manage my pain more effectively? What might life look like a little bit differently? And is there the possibility that I might still be able to do certain things even though they're not exactly the way I did them before? We'll hear a bit more about this later as well, I think, but the patient's individual pain experience is very important, I think, to understand in terms of what they believe is happening, but also the context of their own treatment. So different patients will have had different courses of treatment. Some will still have active disease, and potentially that is impacting their pain levels, and for other people in the survivorship phase there may be no ongoing threat, and so it's really understanding whether or not there is a physiological explanation behind their pain, and understanding how that sits with the patient's understanding about what's going on in their body. I'm also really interested to understand a little bit more about the relationship between cancer pain and fear of recurrence. I think clinically we're seeing a lot of patient worry being driven by, is my cancer coming back? And the same with their pain. I think in our setting there's the requirement that patients have consistent and regular medical follow-up. That has to happen to ensure that there are regular scans and treatments, and so there's really a need to work with patients to balance this avoidance versus hypervigilance, both to their pain and their worry about their cancer coming back. I guess as to summarise this section, there's really obviously a way to go in the cancer pain literature from a psychological perspective, and it's important for us as clinicians to continue to understand where that literature is at, and so that it can inform our practice. I'm also keen to read and understand new sort of evidence-based cancer-specific models and theories that are coming out, because I think that it is important for us to work within this population, as they are quite unique, to understand how they might also differ from the general chronic pain population, who may have sustained an injury, say, and now there's not necessarily ongoing pathology, whereas that's not always the case in the cancer population. I've just put this slide up there, not to really talk about it so much, but just it might be of interest to some people. It was a paper that was a theoretical paper really published earlier this year in the Pain Journal, which was proposing a model, a cognitive affective model of symptom appraisal in the context of pain and cancer recurrence. And so they brought together some theories from chronic pain, brought together some theories from fear of recurrence, and it's interesting to see the interrelationships between the cancer context, the way people behave and respond to the different perceived threats, and how this might interact with pain. And it'll just be interesting to see, I think, how some of these specific cancer theories develop, and if they do some research into this to see, is this happening in the real world. So in terms of what we've learnt, I guess, over these last couple of years is, I guess, we've developed an increased understanding of the role of psychology and the needs in this patient group. There's been an incredible opportunity to enhance relationships and communication between clinicians, and I think that's really led to education between us about what it is that each of us do, and developing an understanding about pain and cancer from different perspectives. The collaboration and treatment planning obviously has been aided immensely by our regular meetings, and it's ultimately resulted in increased referrals and earlier interventions for patients. So in terms of numbers, for example, we would have had a handful of referrals prior to starting. Patients were still eligible for our service, but with streamlining of referral processes in the first year, we had over 40 patients access our service, and it's grown again in the last year. In terms of the next steps for us, what we would like to do is quantify and do some measurement of the patient experience and appraise our ongoing service development to see, is what we're doing actually doing what we think it's doing in the way we'd like it to be done. We're looking at implementing screening and use of risk factors for automatic referral as well, not to remove clinical judgment, I think that will always be there, but also just to perhaps remove some of the barriers, system barriers and individual clinician barriers that might arise in the context of busy clinics. And we'd like to step towards thinking about, well, what are the best way to meet these patient needs in terms of interventions based on the current research and also maybe sort of progressing understanding in this area. So this brings us to, I guess, what are the next steps in developing interventions that are targeted to this group. I think we'd like to look at some education programs, perhaps look at intervention or prevention interventions for at-risk groups. So, for example, people who might be vulnerable to developing post-surgical pain, particularly with some of our significant surgeries that happen at Peter Mac. We haven't had much of a chance to discuss today, but I think there is work to develop ways of working in the acute setting immediately post-surgically with patients on the ward, and looking at the role of individual versus group interventions, and looking at their relative effectiveness to see, can we capture more patients? Can we make the psychological and psychiatric intervention more available? And also learn more about, well, what's appropriate for patients at different stages of their disease. Tim didn't touch on this, but I think the next stage as well in research is that he's going to be leading the charge in hopefully developing some cancer pain specific research at Peter Mac, and hopefully at some stage we might be able to ask some of these questions around looking at screening measures, interventions and piloting, and understanding which components of psychological interventions are most effective, and hopefully that will happen as well in the literature more broadly. That's me for today. Thank you for your attention.
Christina, any questions for Christina?
Yeah, thanks, Christina, for a terrific talk. And with the people who come to the clinic, you didn't give any data on their characteristics. I'm wondering about this issue of how many of them have painful comorbidities rather than pain from their cancer or their treatment.
Yeah.
And what do you do with them?
It's tricky because I think we get people who have cancer pain specifically that's quite unique. There's also people who have pre-standing pain presentations. And in terms of data, Tim might be a better placed on numbers of those presentations to answer that. But essentially, I guess for my work, it's that there has to be a cancer-relevant component, whether that be to the pain and or their psychological distress. And then we would work with that on a case-by-case basis. Did you want to speak to the...
Yeah, it's probably 60% post-surgical, probably 25% post-radiotherapy, and the rest medical oncology. We haven't joined in the EPOC stuff at the moment. Actually, a good question for anyone would be your advice on that, because we're trying to be a bit of a fleet-footed service that aims to prevent post-surgical pain as one of the things that we do. So is it worth us joining EPOC? We were probably thinking of just doing some basic screening at the moment, DAS and self-efficacy and catastrophizing. If anyone's got any thoughts on that, that would be greatly appreciated.
That's what EPOC is.
It's quite long though, isn't it? And it's quite... So we were going to sort of streamline it at the moment. So we haven't done formal demographics or anything else at the moment.
Thanks for a great talk. At our centre for patients who are like cancer survivors, we offer them the one-day pain education day, which is the job program. Do you do a similar thing like for cancer survivors?
Not officially at this time. We have over the past 12 months developed a range of psychosocial wellbeing education seminars, and one of those has been a chronic pain or managing persistent pain talk. That hasn't been able to be rolled out regularly, but I think that's probably one of the first things that we'd like to do as either just an education-based program in itself or incorporating some skills as well. And that's probably the next step. So I'd be very interested to hear about that at some stage.